will be more so acromegaly, but we're happy to answer any question in general about pituitary or tumors, surgery, medical therapy. So yeah, so I'll introduce, you probably know who we are by now, but our photos are behind us. I'm Susan. I'm one of the new endocrinologists. So this is our nurse practitioner, Olivia Chu, Dr. Andrew Hoffman. He's one of our endocrinologists. And then obviously we have Jill, who's the president of the Acromegaly Patient Society. So I prioritize patient. If you're here live, you get dibs on the questions. If there are no questions, then I go to the Zoom audience. Any questions? Yeah.
My question is.
Oh, it's okay. I'll repeat the question here. Yeah.
Right after my surgery, we've already talked about weight. I did put a lot of weight on that I felt like was out of proportion to what anybody could eat in that short period of time. But the other piece too is I lost a lot of hair. And I don't know that I've seen that. I mean, when I tried to research it, I wasn't prepared for it. Unfortunately, I have a lot of hair. Maybe I had a lot of hair because of that. And then I went back to normal. I mean, my family, everyone in my family has pretty hair. I would say I probably have a I have now. So thankfully it's not a lot, but it was a huge, huge thing to be gaining weight and losing hair. But is that a documented? I mean, is it, because I asked another people, it's like, a good answer. Because I don't have a thyroid, so they thought, well, maybe it's a thyroid. That's not, I just wanted to know, is that a thing?
Yeah. So I'll repeat the question and then our panelists can answer. And I'm assuming acromegaly. Okay, to share. So the question is, in patients with acromegaly, how can that affect weight and hair loss? And is this before or after treatment or both? After surgery. So how does having surgery for the treatment of acromegaly affect your hair and also your weight?
So within our discussion groups, we see hair loss very common post-surgery. From what I understand, a lot of physicians say that due to the acromegaly, that we have thicker, more hair than what we should, and it's going back to what your new normal is. Most, and I'm not trying to minimize it, but like you said that you might have a third, but your hair looks normal. And it might have been that because of the acromegaly. Yeah. Yeah. But I hear it all the time within the discussion groups, especially post-surgery, patients panicking because of the amount of hair loss that they have, but it typically levels out and it does get better. So.
Of surgery.
Yeah, with the knowledge that I have, when patients come to me and they tell me that they're losing hair, the first thing I say is, "Have you had your thyroid checked?" Just to make sure that that isn't an issue. But if it wasn't an issue with you, I would say that it was just going back to what should have been to begin with, pre-tumor.
Yeah, I agree with Jill. I think hair loss is so multifactorial. I don't think anyone can ever say for sure it was purely because you had the surgery. Thyroid is the probably more common hormone that has a direct, we know for a fact that it can cause dry skin, hair loss. But after surgery, with even though your pituitary gland is intact, they're in there, and so there's transient hormones, the stress of surgery. So stress is a known factor to cause hair loss without pituitary. So it's probably multifactorial. And we do, we do have patients who come out of surgery having this, and thankfully most of the time it gets better. Yeah. Great question. Yeah, go ahead. No, I'll repeat your question.
It is like such a number one issue for us. So it's great to have lab numbers that are coming back to normal, and like it's nice that like, wow, I'm in remission now, like, maybe permanently. But like, I want help. Like, the emotions I have about my parents, and I don't know. And it's almost like I need almost like a checklist or an overview. Okay, what is priority? Is it my mental health because I have an eating disorder or weight? And now to have this on top of that, I'm always like, well, just try harder with your surgery. Then it's also like, well, it's always diet and exercise. It just like pierces me in the heart because that's hard to do already. But is this like the only thing that improve my spirit? The weight loss thing is big on my mind because I appreciate but also sort of like how do I moderate my expectations? What should I shoot for first? What's the easiest thing? How long does it take to be successful to feel good about it? It's good practice, but yes, I'd like to still improve the way I look. I want to take more meds, but I'm hungry all the time.
Yeah.
So can you explain that too?
Yeah, that's tough. Yeah. And so, yeah. And so I just wanted to clarify, physical appearance in terms of the acromegaly classic features, or more so weight and the weight gain after surgery.
How much of it's controlled?
Yeah. And this is before surgery or after surgery? Okay. Sorry, I just want to clarify so I can tell the audience. Yeah. So the main question is, how do we improve, not just our mental health, but also, the way we feel about ourselves and our weight, because that obviously has effects on, how you look at yourself after surgery. Jill, I'm going to let you do this one because I think it's best to share what other patients have done.
So I can tell you what we see within our group. As I said next door, weight gain is super common. And I tried to express post-surgery, so many patients are hungry, uncontrollably hungry. And I believe it's because, yes, they removed the tumor, but the ghrelin hormone is still off. Ghrelin is a stimulating hormone for growth hormone. I can tell you that many 100+ patients within our group have used GLP-1s in combination, and they've had tremendous success. Just the other day, there was someone within our group that said that they had lost over 100 pounds. And it wasn't even a high dose GLP-1, like Wegovy. It was one of the lower. I think, the GLP-1s there's some new research with them. They're being studied for sleep apnea. They're being studied for so many different things, symptoms that acromegaly patients have. And I think sometime in the future, it might even be standard of care, adding something like that to our regimen. Because with acromegaly, I was talking to Jennifer, You know, we tend to be more muscular and such than what the average human being is. And with the GLP-1s, they've also found that not only do you lose weight, but you also lose some muscle. And, you know, it also improves cardiovascular health. There are so many different things. It's been studied with sleep disorders. You know, I think that there's a lot more study that needs to be done. But we're trying to actually put together a clinical trial with using the GLP-1s in combination with our therapies. Or for even the people in remission, because of the issues post-surgery that patients face. You know, it's not an easy answer, but I can tell you that a lot of patients have had a lot of success. You know, unfortunately, now a lot of insurance companies are refusing payment, you know, for those, that class of drugs. And patients have seen so much success that they're self-paying for it. And they're not cheap. They're over $1,000 a month, but patients still do it because they've seen so much improvement by using that in combination. So.
Yeah. So the weight gain after pituitary surgery and, you know, cure of whatever tumor you had is something we do see quite often. And it's kind of like the hair loss. And it's like, it's probably multifactorial because as endocrinologists, we're quite limited to, is there a pituitary hormone deficiency or excess? And if there is, then we either give you back whatever you're missing or control whatever is too much. But if those numbers are all level, then those levels are normal, then, you know, then we're reaching out to spaces of medical therapy that we're not trained in. So like weight loss therapy, which is multifactorial, hormones, you know, hormones like ghrelin that Jill mentioned, you know, it's mainly made by the gut and less so, but there are, you know, studies that show that there is some stimulation in the pituitary gland and it makes you feel more hungry. But it's not, we don't commonly check ghrelin levels. There's a Zoom audience that asks, you know, is there a serum ghrelin test easily available? What are the normal values? Is there a replacement for ghrelin if someone has panhypopituitarism? Is ghrelin regulated by the pituitary gland? And, you know, to answer some of those questions, ghrelin is not one of the common medications we prescribe in patients with panhypopituitarism. Oddly enough, I don't see why, if you're having issues with weight, ghrelin makes you hungry. So we should not give you ghrelin. And whether or not, you know, I don't, you know, maybe an obesity clinic or something measured ghrelin, but we don't measure ghrelin. So I don't know what lab assay is the best, what normal values are, but we do not routinely measure or give it to you.
So Inner Scientific Quest, they have an assay for the ghrelin hormone, but it's not readily available. It's not the easiest test to get. I have had my ghrelin tested, but I had to have a world expert walk the lab through the process. And it's not easy. So that's why if we can put together studies like the one that Novo Nordisk is doing, that's willing to go to a patient's home and send a nurse and just get a blood draw. It's helpful, you know, for the science. Nothing will be done about these issues until there are lab values that prove the hypothesis.
We don't know. Yeah, we don't know.
Yes.
What are normal. You can get the test, but we don't know what to do with the result.
Correct.
And that's assuming ghrelin even has anything to do with this, right? This is just a theory.
You say we could initiate, or we are working on clinical studies. Who's we?
So right now I'm helping to promote a study for Novo Nordisk, the maker of one of the GLP-1 drugs. And there's a sign up within my group where you can sign up and they'll screen you. And if you qualify as an acromegaly patient, they will send a nurse to your home and do a simple blood draw, and they'll pay you for your time. You know, it's a small study. They want, you know, 25 or 50 samples. You know, but we have to make sure that there's proof of concept before we move forward with anything else. And I just think that there's so much more to be learned regarding acromegaly. And science is doing its best right now with what they know. But there's a lot more to be learned. So that's just my opinion.
Sorry, another unsatisfactory answer to your question. Sorry, there's so much to do with, you know, how a person loses weight. And it's even more than just pituitary, you know, like hormonal, like if you're perimenopausal, you know, it's a known fact that once you reach menopause, you will gain weight because your metabolism just slows down. You know, it's so multifactorial. But yeah. Any other questions? Yeah, sorry, she raised her hand first. So I'm going to go with her and then I'll go with you next.
She had her surgery in June. She's still dealing with she's not taking any medication. They're going to be typical.
So the question is, in a patient with acromegaly who's had the tumor resected, there is some residual tumor by the cavernous sinus, but all of her biochemical hormone, I'm assuming her IGF-1 has been normalized, not on any hormone medication therapy and having post-operative fatigue, especially in the afternoon. You know, what do we make of this? And is there any treatment or further workup for it? Yeah. It's a great question. We'll separate the two. So I'll ask that next. Yeah.
So I know that before we had our modern day treatments, they used estrogen to treat acromegaly. That's what I've been told by multiple people.
Yeah, we used to use estrogen. Estrogen really blocks the effect of growth hormone on the liver, so it can't make IGF-1. So estrogen will lower the IGF-1 levels. And if you stop the birth control pills, they'll probably go back up. You know, as to your fatigue, there are many causes of that. But normally a year after surgery, and if all the hormone levels are truly normal, then you shouldn't be fatigued from a hormonal basis. So, you know, the question is, are the other hormones truly normal? Sometimes it's difficult to assess thyroid function and adrenal function unless you do stimulation tests for the adrenal. And, you know, if the free T4 level is on the high side of normal, low side of normal. So those are issues. And if your endocrinologist has evaluated that and feels it's everything is fine, then I think I would look for other causes of the fatigue.
I add, has he post-surgery, have you had an oral glucose tolerance test for a growth hormone just to confirm? So you didn't have one pre because your IGF-1 levels were so high? You might I mean, if it were me and I were dealing with that, I might say, hey, you know, what harm would it do for me to do an oral glucose tolerance test just to make sure that I'm in remission? Do you?
Yeah, there are occasions when the IGF-1 is normal and the growth hormone does not suppress
Yes.
after glucose. And in those cases, you'd want to probably do some either further surgical or pharmacologic treatment. So that would be worth looking at. You weren't fatigued before surgery, is that right? You were fatigued before. Okay. I mean, there may be other issues, but I think an oral glucose tolerance test would be interesting to do, and it's worth discussing with your endocrinologist.
And then, you know, conversely, so an oral glucose tolerance test would help us determine if the tumor is actually making too much growth hormone, and for a reason your IGF-1 level remains normal. So it's like a false normal. Conversely, if you have growth hormone deficiency, which can make someone feel a little tired, that would be a different, you know, a glucagon symptom. So basically, just testing if you have too much growth hormone, too little growth hormone. But I agree with Dr. Hoffman. If your hormonal, post-operative hormonal panel, cortisol, thyroid, you know, further testing into your growth hormone status, if those are normal, then we'd have to look at other causes of your fatigue.
And do you know, have you had any 8 a.m. cortisol tests done?
Yeah. Okay. And then, sorry, yes, you had a question.
So, wife has IGF, my wife has had a surgery. And IGF is under control. Actually, just checked, it's things on 166. Yet she is still experiencing symptoms such as fatigue in the afternoon, joint ache. She also has diabetic. We felt that when her diabetics is better, her symptoms seem to be less. I want to ask you and the panel any common feedback during examination based on.
And she had surgical cure.
She
Surgical.
surgical procedure.
She's on medication.
Okay. Are you on medications to lower your cortisol level, or sorry, your IGF-1 levels?
She's on the injection.
Yes,
I see.
So modulant people.
So the question is we have a patient with acromegaly, had surgery to remove it, but still needs medical therapy to keep her IGF-1 levels in a normal range, but she still has symptoms that could be kind of like acromegaly with joint pain, diabetes, and it's interesting that when her blood sugars are controlled, the joint pain and other symptoms also improve. I'll leave it to Dr. Hoffman.
I think that's a good indication for really working hard to control the diabetes, because that can cause a variety of different symptoms. I don't think either of those are classic symptoms of this matchline, so I don't think it's the drug that you're getting. You always have to consider other medications you might be taking that could cause fatigue. The arthralgias, they are from the acromegaly, sometimes don't improve very much, even with treatment. If you get arthritis, the osteoarthritis, it sort of doesn't really improve that much, even when the acromegaly has been cured. So other approaches have to be made for that. But I strongly encourage you to control the diabetes as best you can for the reasons that you've outlined, but also just for your general health.
You need to remember that we don't process sugars properly. In a normal person, when you drink glucose, growth hormone bottoms out, goes to 0. In someone with acromegaly, it remains elevated. So it's extremely important for you to try to control those blood sugars.
observation,
Mhm.
you don't have a relationship. My experience, what I feel is, I take my injection, and my morning blood sugar is really hard to control. The baseline is usually like 130, 140. Like in the morning, without I try it. But towards the end of the month, if I take my injection a couple of days later, that 2 days, the blood sugar is I'm a 1 or meals are all very similar. So I feel like it has a lot to do with the injection itself
Mhm.
rather than the other.
What are you taking? Are you taking insulin, by the way?
Yeah. What's the name of the injection you're taking? What's the name of your medication?
No, the injection is
Oh,
lanreotide. Yeah, and are you, for the diabetes, do you take insulin injections? No, for the diabetes. Metformin. Yeah, one of the potential side effects, although it doesn't usually happen with the somatostatin antagonists, is that they can also decrease insulin secretion. So it may be by the end of the month, your somatulin is essentially going away, and you're no longer suppressing the insulin from the pancreas. That doesn't usually happen with this drug, but it can.
And do you take the metformin before you go to bed at night?
yeah. From what I'm hearing, I think it could be the monthly injections. There's some that are worse in terms of worsening your blood sugars. This one is less common, but I could see it possibly doing that. And the theory is that it actually decreases your pancreas' ability to secrete insulin. If you don't have enough insulin, your blood sugar is high, and as the medication wears off, the pancreas is making more insulin. So that is interesting.
Recently, I've been monitoring.
Mm.
For years, I never made. Now that I'm on that monitor.
Hmm. Interesting.
Make
Yeah, I think you got to show that to your endocrinologist, and they can make some adjustments, perhaps.
And you have to remember that growth hormone is typically highest in the middle of the night. And everything goes in a feedback mechanism. From what I've seen in the group, there's lots of patients that whenever they do have high blood sugars, it tends to be in the middle of the night. Especially some of them on the SSR2 medications. Yes, it's in the middle of the night. It's not during the day.
The patients, is there anything that can be done to alleviate that fire in the middle of the night?
We can modulate other medicines and find a way to handle that.
Yeah. Yes. To answer your question, yeah. So the crux is this: if your high blood sugar and diabetes is truly related to an adverse reaction from your monthly injections to control your acromegaly, what can we do? I think the best answer is that whoever your endocrinologist, they would have to look at your blood sugar trends, not just from day to day, like day and night, but throughout the month, right? Because if that's truly what's happening, we can't give you the same medication throughout the entire month, right? Because your blood sugars will bottom out by the end of the month if your blood sugar isn't high, and we give you super high doses of whatever diabetes medications we decide to give. So I think you need a very personalized and tailored approach to your specific blood sugar trends. Yeah. Yeah. I think you should work with your endocrinologist. So yeah, because it depends on how high your blood sugars get. And metformin doesn't really have any effect on the amount of insulin your pancreas puts out. It does not. It works in different ways to lower your blood sugar. So that's why it's like, we might need to try different meds. We need to do, you might have a different therapy the first week of the month than the last week of the month. I think you need a very tailored approach if our suspicion is correct.
We're trying to be our own doctor.
Yeah.
Otherwise, I do have something.
Let's see. Any other questions? Yes.
This might have been answered earlier. Symptoms in particular.
So the question is, what are the chances of the tumor coming back after having had surgery, and what symptoms do we look for? I think so. So the chance of the tumor coming back really depends on how good the surgery went the first time. If sometimes the surgeon, if they left something, the chances that it comes back is going to be much higher than if the surgeon really thought they got everything out. Yeah.
I think she also had radiation therapy, correct? Yeah.
Oh, okay.
I think she was based here at Stanford.
Mhm. Yeah, yeah. So yeah, I think it's the more they leave, the higher the chance it comes back.
Yeah, like percentage.
It's so patient dependent. And so if anything, there's studies that show your post-operative day 1 and day 2 growth hormone giving you a statistical chance of surgical cure. Like you will never have this again. And so growth hormone that they check the first and second day after your surgery, if it's less than 1, that is you have a more than 90% chance that it will never come back and reach surgical cure. So do you remember what her growth hormones were? So that's the one thing that I know. I don't know if there's other things that predict, Mhm. 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 I see. And yeah. And then now I'm hearing she got surgery, didn't get everything out, and also had radiation. Yeah. So the radiation will take years to work, as you know.
Right. So
Yeah.
we have a stim test to see if there's a
Cortisol.
Yeah.
Reevaluating internal.
So with radiation, I mean, that improves your chances that this will not come back, but it will take years to work. Radiation will also increase your chance that you get pituitary hormone deficiencies, which it sounds like she already has with, she needs cortisol and she needs thyroid hormone. So it's the rate at which it will come back really is so patient specific. I can't give you a number. Like you're going to have an X% chance of it coming back. It just depends on yourself, how the surgery went, how much is left, what was your growth hormone the day after surgery, so many factors. And then, to know when it comes back, it's really the same signs and symptoms that you had of acromegaly. Yeah.
how long you're using CPAP first.
Mm-hmm.
Yes.
Yeah. Mm.
9:30. I personally noticed her sleep apnea's gotten a lot better. She's still pretty, it's a lot less now.
Yeah. So the next question is, the subject is sleep apnea and acromegaly. So yes, if you have reached, the reason why patients with acromegaly have sleep apnea is the soft tissue swelling. If it's in the throat, then when you sleep and you lay flat, the throat soft tissues will collapse on your breathing tube, and then you snore. You're literally gasping for air because you can't breathe. So that's obstructive sleep apnea. When you get the surgery or treat medical therapy, whatever therapy to lower your IGF-1, the soft tissue swelling should improve. So after surgery, we often say this is you tend to pee a lot after surgery because the liquid is literally coming out of your soft tissue and you're trying to diurese because you're reaching cure. And so the fact that her sleep apnea you think is getting better after surgery is expected. However, some patients will have a permanent obstructive sleep apnea, and to know whether or not she needs to continue using her CPAP is to repeat the sleep study. she should see a sleep medicine physician. They do a sleep test, and if she still has sleep apnea, then she should continue wearing the CPAP. Yeah. Oh.
There's different
Mhm.
stays, right? You treat it.
Yeah. Yes. So there's definitely more options for CPAP machines that are more comfortable. The best person you talk to is a sleep medicine doctor. We don't prescribe those, but there are better technologies that make them more comfortable. There's mouth guards that keep the jaw open. There's pros and cons to all of these newer treatments. So she should definitely see someone, because having uncontrolled sleep apnea has other health effects long term.
So, on our Facebook, YouTube site, under Acromegaly Community, we had a sleep specialist. You can go through and see, he did an hour-long talk at our international meeting earlier this year. It was one of our most popular talks. You go to YouTube, look up Acromegaly Community, and there's a whole host of talks. And it says sleep specialist on it, and watch it.
Don't have everyday access to a complete care. Patients for how we can advocate for ourselves among doctors who aren't necessarily as educated or specialized on academic. My kids now, I went in, I was like, oh, and they sat there and Googled it in front of me. Like, oh, this is not a great start. Are there recommendations on like what to help me?
Yeah. So the question is, how do patients get access to a more complete care team that truly knows what acromegaly is? And I think it's tough because acromegaly is extremely rare. And so we can't expect general practitioners to know, what it is, let alone how to treat it. And so if you're in a situation where you go to a physician nearby and tell them I have acromegaly and they're Googling it, I think the first thing you say is like, hey, can you refer me to an endocrinologist? And, even then, if the endocrinologist is not at a pituitary center and don't have it, then you just say, hey, can you refer me to an endocrinologist at whatever academic institution is closest to you? And, I said this at the last session, but asking for second opinions, like there's no harm as a patient to ask for a second opinion or ask for a referral from your general practitioner. And so, it's not so much, like you can't expect a general practitioner to know how to treat every rare disease. And yeah, that would be my personal advice. I don't know if you have other.
And one of the things that patients do within our group is they put where they're at and they say, does anyone know of knowledgeable physicians around? And that's extremely helpful in my opinion. Another thing that you should know is that there's clinical guidelines, printed out that you can print out on how to treat acromegaly to take to your physicians. But we have seen that if patients go to a doctor that they're typically the only patient that doctor has ever seen with acromegaly, they don't get the quality of care that they need, because you really do need someone to help manage this condition collaboratively with you and know the ins and the outs of it in order to try to regain the quality of life that you lost due to this disease.
And if you think you need to bring the guidelines to the doctor, you still need a different doctor.
100%.
Like they can go through the algorithm.
But we've had patients in Alaska, and they're like, what do we do? And it's like, you make sure that you're educated yourself. And if you have to travel, you have to travel. But education is the most powerful thing that you can do with rare disease, in my opinion. It gives you the power to know if you're getting the proper treatment or not. So.
Our pituitary centers, with
No.
There's 3 in New York City.
East Coast and the West Coast.
There are other pituitary
Yeah.
centers, but there aren't that many. There are 2 in Northern California and probably 3 in Southern California.
You guys are really lucky in California to have the quality of care that you do. I live in Oklahoma and I don't get my care in Oklahoma. And I have to pay out of pocket, even though I pay for my insurance. That covers me in Oklahoma. Just because I know, you know, the difference in the quality of care between someone that is knowledgeable and not. So very, very fortunate.
My hand, right, they're bigger. That's swelling, or is that like more fat? Inside my fingers that gives the. I'm curious because I'm always touching it, palpating it, it hurts, achy, and then I'm always like wondering, is this ever gonna change? And again, it's back to that body thing, but
You know, a lot of the soft tissue swelling will go down after surgery. Then you're left with some enlargement of the bones and with some arthritis in the joints. And the bone changes may change slowly over many years or may not. The joint changes are not going to improve. Pretty much, yeah. And, you know, there are other treatments, but it does cause, acromegaly does cause arthritis, and it's an osteoarthritis, and it can be very painful, of course. But it will generally be like any other form of osteoarthritis after your treatment, and you'll need to have other forms of treatment. It will not get better on its own.
Okay. Yeah. All right. One last question. Yeah.
question in terms of comprehensive acromegaly symptoms. I understand that we go to specialists, we go to surgeon, a specialist. You know, daily life deal with a lot of other symptoms like in the like and all that problem, I would send to different specialists. And I can find them, go to a hearing doctor, they run some tests, they give me some field chart. My question is, yes, well, we cannot expect that everybody else to be familiar with that. As an acromegaly patient, are they managed or should they be treated the same way as people who don't have acromegaly? Hard here if those doctors are not trained or familiar with this condition.
I think the question is, you know, how do we manage symptoms associated with acromegaly when it's not an endocrine issues like joint pains, for example, or dental issues or hearing issues? And so the main thing is to get to treat the tumor, remove the tumor, and get your IGF-1 levels normal. Like Dr. Hoffman mentioned, some of those symptoms may be permanent, like arthritis. You know, your soft tissue swelling can improve after surgery, but sometimes your arthritis, you know, joint pains won't after surgery, unfortunately, even though your growth hormone and your IGF-1 is back to normal. And so for those, I would in general say that the treatment would not be that different. So if a patient came in with joint pain, you know, arthritis, and they don't have acromegaly, and the best treatment option from the prescribing doctor is, you know, steroid joint injections or something every 6 months to help, I don't see why a patient with acromegaly who's now in surgical remission should be treated that much differently, right? Because the main goal is to treat the acromegaly, get your growth hormone, and then the residual symptoms, like for example, your ear infections, you know, an ear, nose, and throat doctor should not treat your ear infections any differently, you know, whether or not, you know, like they would treat you as if there was a patient with that acromegaly.
day until it's
Yeah.
very bad.
Yeah. Yeah, it's just the bony. Yeah. So some of the bony thing, yeah, the bony things are permanent. So, or we hope not, but in some cases it is. And so the treatment would be sort of how they would treat ear infections as they would normally, or how would they treat arthritis? Right, in general. All right.
I think that the whole goal is to get acromegaly under control rather than acromegaly controlling you. And that's what changes the quality of life for patients. And, you know, be as compliant as what you can be with your medications, you know, be as proactive regarding your care. And, you know, see the specialist that you need to. Because it does take a team to manage this disease and all of its comorbidities. And unfortunately, it's like a job managing this disease. You know, but with proper care, you typically do better. So, and you always have to remember that you're worth this extra work that it takes to feel better. I know it gets tiring, but you're worth this extra fight that it takes to try to regain your life back.
I'll add that, Joe, the Facebook we set up has been very helpful. Part of this.
Thank you.
Shout out to Jill's Facebook group.
Thank you.
All right. Well, thank you, everyone. I hope today was as enjoyable for you as it was for us. Thank you. Yeah. Yeah. I think people would like taper off.